For allowing me to be a part of this course. I've been asked to cover some important topics and points about post-keratoconus and keratectasia. I guess perfect cataract surgery everybody does. This patient walked in 2 days back into my clinic, and they're so happy they want the other eye. And even the best of surgeons on the dais might find it slightly difficult to get that kind of vision with this kind of a cornea. And it can, of course, make your head spin. Broadly, patients with corneal disease can be epithelial, stromal, or endothelial. And this is one patient, history of rheumatoid arthritis, a Schirmer's 1 millimeter, T breakup time 1 millimeter, and ocular surface disease index is severe. And this is something that I do recommend for anybody beyond 55 to at least do a quick Schirmer's, and tear breakup time doesn't take too long. You're checking the intraocular pressure anyway. He's a biochemist. He's got a history of using eye drops for glaucoma and complaints of dry eyes. And his first complaint is, doctor, when I cry, I don't get tears. I said, why do you need to cry? He says, my wife beats me. I said, I understand. I've been married for 12 years too. And broadly, after putting the punctal plugs for him, you can make out the ocular surface is a lot better, and he's actually settled down. Smart plugs, I won't go into detail, but just to suffice that doing them pre or post-operatively would be a good option. Remember, a lot of them have borderline ocular surface disease. It can occur even after uneventful surgery, and at least do a Schirmer's or a fluorescein staining. This is the ocular surface disease index. It's been quantified, and broadly this is how I approach. And if you have an opacity which is full or partial thickness, central or peripheral, anterior can be epithelial or stromal, and posterior you could have endothelial with or without scarring. If you have corneal scars, corneal dystrophy, or corneal ectatic diseases, the approaches are slightly different. If you have stromal diseases, which basically have peripheral leukomas, a cataract surgery alone would do, but you need to plan for an eccentric rhexis. If you have a scar, something like this, you would need to base the rhexis out into the visual area so that you release the synechiae, you place the rhexis in the clear area, and a phaco or SICS even would give good options, and prefer to do a direct chop, and all visible maneuvers need to be in the open area. This is one other patient, history of bilateral corneal opacity with eccentric fixation. You could do a PK-ECC IOL, or you could do a phaco IOL alone. Remember that PK requires lifelong follow-up, and in this we just modify it slightly differently by basically using endo-illuminator, which helps with your limbal illumination, and you can then do your procedures in the eye quite comfortably. Also, remember that you follow the tenets of actually doing the surgery in terms of using good viscoelastic, and you would also basically not aim for perfect visual outcomes in this patient. We did use a lot of viscoelastic. We did use a ring to actually enhance, and it was not that easy a procedure, and you can actually still make out the endo-illuminator that helped. In cases of HSV keratitis, remember that a lot of them do require acyclovir before you plan to do surgery. And if you have patients who are 45 plus with lattice dystrophy, a lot of them would actually do well with a cataract surgery alone, wherein the visualization can be helped with endo-illuminators. If you have central scars, if you have a post-keratoplasty patient, remember that you can do sequential or combined. In sequential cataract surgery, it's probably more predictable. You remove all the sutures, but you need to do 2 surgeries. You can do a standard K with a single surgery, and it's of course surgeon dependent, and you have an open globe surgery risk. You could put in the illumination in the vitreous. That also helps. This is one other patient, business or government contracts, diagnosed to have cataracts at another hospital, underwent RK for a myopia of -8. And her children are doctors. Son is actually a clinical trial specialist. He's done intensive research on various types of IOLs. He's read my papers, and son actually discusses the post-op results, including confidence intervals. After surgery, the doctor actually did well. The patient is a Christian. He wants to basically be close to Jesus. We included preoperative antibiotics, and my preoperative preparation included prayers. And luckily for both them and me, the surgery actually went off very well. And you can make out the RK. Remember, in RK, the incision, if it's 50%, most of the time you would get. It's important that you do a good preoperative evaluation to check how deep the previous RK incisions are. In this, we were good. We were lucky because one is the astigmatism is actually quite regular. So you put in a toric lens in these cases, they would actually respond quite well. At the end of the day, hospital was happy with the income, and I was happy with the outcome. It's also important that you follow these patients up. Some of them do have a bit of post-op fluctuation in the vision, which could be because of initial hyperopia, so you need to be patient for at least a month. Sorry. This is just a video of reasonably advanced keratoconus with mature cataract, but the important part in this was basically that we used the toric IOL predominantly because if you see the topography, it's predominantly regular. And a patient came with a mature cataract, and he was looking actually for visual rehabilitation. The treatment, of course, quite standard in terms of what you're planning to do. The surgery went off well. We used a T9 in this, and the patient now has a follow-up of 1 year with a very, very stable IOL in place with 6/9 plus kind of vision, though we did give him glasses for post-op visual acuity. Occasionally I do get these cases which require lamellar keratoplasty, but important thing is some of them do end up with very, very significant amount of cylinder, like this patient is about 6 diopters, and we did do a study which was presented at the ASCRS where we had 5 eyes post keratoplasty. Almost about 80% would see quite well. 612 is there in almost about 100% of these eyes. Of course not as good as you would like compared to the standard toric IOLs, but pretty good nevertheless. A lot of them have a good improvement post-op. A bit of hyperopia is preferable because there can be a post-op inflammation in post-graft eyes is slightly more. This I would skip because this has already been discussed. But in a patient with previous corneal graft, remember that topography and endothelial cell counts are mandatory. You do a limbal incision to avoid the graft host junction, and meticulous technique with viscoat with slow-mo phacoparameters. This is just a video to show that even in a in a post therapeutic keratoplasty, we did a customized IOL in this patient. He had about 6 diopters plus cylinder, but a regular one. And because he had a post inflammatory cataract, you need to make sure that you get the rexus. A lot of them have a inflammatory membrane that needs to be removed. The cataracts are generally quite small, and most of them, if you have done your pre-op planning quite well, we used a plate haptic lens which was placed at about 150 degrees, which was customized to this patient, and the patient is now about 3 years post-op. I'll end with this because I think we're short of time. Thank you.